Hello, everyone. Thank you for coming. Welcome to NAHDO's 40th annual conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsors. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find more information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win prizes in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Oh, thank you, Debbie. It's so fantastic to be with you here. It's been a wonderful day. We've had such good sessions. I hope that you've enjoyed them as much as I have. This session is titled State Showcase Policy Insights, Market Dynamics, and Care Model Analysis. It was organized by Betty Harney, who will also be today's moderator. So Charles, let's go ahead and bring Betty to the stage. Betty, I'm going to turn it over to you. The stage is now yours.
Hi, I'm Betty Harney. Greetings from New England. I am very pleased to be able to moderate this session, which is about, as Norm just said, policy insights, market dynamics, and a care model analysis. We have some wonderful presentations from Massachusetts, Virginia, and Vermont. First up is Massachusetts, and I am honored to introduce Charlotte Burlingame of the Health Policy Commission. She's going to be presenting her team's research results on the hospital at home program here in Massachusetts. Take it away, Charlotte.
Good afternoon. My name is Charlotte Burlingame. I'm a senior research associate at the Massachusetts Health Policy Commission. And I'm here today to share some work from a recently released policy brief on hospital at home. We'll start with a brief bit of background on the program. The purpose of hospital at home is to provide inpatient-level acute care services in a patient's home. Although some hospitals in Massachusetts experimented with hospital at home in as early as 2017, programs really began taking off after CMS launched acute hospital care at home in 2020. The goal of this program was to alleviate hospital capacity issues during the pandemic. Under Medicare's program, hospital at home stays are reimbursed at parity for a traditional inpatient stay. Hospital at home attracted hospitals in both the Commonwealth and nationwide because of this potential to manage capacity. And the program was extended by Congress through a number of short-term waivers, with the most recent expiring in September of 2025. Although there is bipartisan support for language that would reauthorize this program included in the congressional spending bill, as of this recording on October 17th, 2025, the acute hospital care at home program is not currently active, so hospitals are waiting to see how this is resolved. Prior to the waiver's expiration, 39 states had hospitals approved for acute hospital care at home. In Massachusetts, we had 20 total hospitals approved, 8 of which had active programs this year. To explore hospital at home utilization, we used our hospital discharge data, or case mix data, from our sister agency, the Center for Health Information and Analysis, or CHIA, which is Massachusetts Data Collection Agency. Case mix is very similar to the national HCUP data. We identify discharges with 3 methods. First, using a revenue code created by CMS. Second, using a site ID requested by UMass. And finally, using a generic revenue code for Mass General Brigham hospitals because they told CHIA that they use this, particularly for some payers that don't accept the CMS code or for discharges that occurred before CMS introduced the code in 2022. Because these programs are so new, hospitals with programs are not all reporting discharges in the same way. For example, Massachusetts had 9 active programs in 2024, but we can only identify 8 hospitals with discharges using these methods. Several state agencies in Massachusetts are working together on an effort to standardize reporting and data collection of the hospital at home discharges. And I want to emphasize the teamwork necessary to make this analysis happen. We had to collaborate with CHIA, with hospitals, and other state stakeholders to collect and verify our data and findings. Here we have the number of hospital at home discharges in Massachusetts from 2020 to 2024. Although discharges have increased tenfold during this time, hospital at home remains a small share of total inpatient discharges, less than 1% in 2024. here's that same graph broken down by hospital. In early years of the model, hospital at home volume was dominated by a few academic medical centers, but many programs for community hospitals became active later on. We were also able to identify some characteristics of hospital at home patients in our case mix data. We look here at the distribution of discharges in 2024 by coverage type, where Medicare patients represent 2/3 of these discharges. Consistent with this finding, more than half of patients with a hospital at home stay in 2024 were 70 years old or older. In addition to payer and age, we were able to identify patient race, ethnicity, and community income. In 2024, the demographics of hospital at home patients by race, ethnicity, and community income were generally similar to the overall inpatient population at those same hospitals. This contrasts with national research, which found that hospital at home patients were more likely to be white and have higher incomes than patients with traditional inpatient stays. As part of this analysis, we compare hospital at home discharges to a constructed group of similar traditional inpatient discharges. We take the hospital at home sample in each year and match to inpatient discharges by matching hospital, APR-DRG, and severity of illness. We then weight the inpatient sample to match the hospital at home distribution to try and get these samples as similar as possible. We're interested in length of stay, discharge destination, and hospital charges between the two groups because they can help us understand the patient experience between settings, such as how long are people staying for the same conditions and what types of services are they getting. We use charges because we don't have costs or prices in our data. Hospital charges are the dollar amount a hospital sets for services before negotiating, or sometimes considered the sticker price. Two hospitals won't have the same charges for the same sets of services, but they're a way to compare resource use within the same hospital. We can see ancillary charges, which are things like imaging, drugs, labs, routine or room and board services, special charges, which usually indicate ICU utilization. And being able to see these components is useful because we can then determine for patients at the same hospital, hospitalized for the same condition with the same level of severity, where resources are being allocated when our observed difference between them is whether or not they were a hospital at home patient. So to turn to some of the results, here we show average length of stay for our two samples from 2020 to 2024. The average length of stay is higher for hospital at home stays compared to traditional inpatient stays, and by more than a day after 2020. One possible reason for this trend might be the lack of hospital urgency to discharge patients to manage capacity, since there is nobody waiting for their bed. It may also be because there's no urgency from the patients to go home from the hospital. In any case, this is consistent with CMS's findings at the national level that hospital at home discharges had longer lengths of stay. These stacked bars compare discharge destinations by setting in 2024. We find that hospital at home patients were far less likely to be discharged to skilled nursing facilities compared to the inpatient comparison group. They were instead more likely to be routinely discharged or discharged to home health. These differences may reflect that candidates for hospital at home may be less acute and therefore less likely to need SNF level care following their stay. But it's also possible that hospital at home may offer advantages that reduce or eliminate the need for SNF care, such as longer lengths of stay, translating to more time for recovery. Here we show average charges per discharge between settings from 2020 to 2024. Remember that we are using charges as a proxy for resource use within a hospital. So here we're trying to identify how that might differ by whether or not someone's a hospital at home patient. We see that the difference in charges between settings, which is the difference in the height of the blue and orange bars, is decreasing over time, indicating that the resources needed to care for these patients is becoming more similar and is pretty much the same by 2024. And to quickly note the drop in charges in 2024, this is where we keep in mind that the composition of discharges by hospital cohort changes dramatically. Community hospitals make up almost half of total discharge volume at this point, and they likely have a lower acuity patient population and therefore lower charges compared to the AMCs that represented most of the volume up until this point. By breaking down total charges by charge type, we learn that hospital at home charges have a larger routine component, represented by the dark orange, compared to inpatient. This likely reflects the longer length of stay we observed earlier, as well as other costs and inefficiencies associated with bringing staff and equipment to a patient's home. We also learned that the inpatient group has a larger ancillary and special component, represented by the blue and yellow. And we can see that total charges are becoming more similar between settings, primarily because ancillary charges are growing for hospital at home. One potential explanation for this trend is that as hospital at home programs become more experienced, they're able to treat more acute patients. So the growth in ancillary charges would reflect the additional labs, drugs, imaging, and other professional services needed to care for those patients. This would also explain the rise in total charges over the time trend, the height of the overall bars. As programs feel more comfortable admitting more complex patients or have built the infrastructure required to do so, the internal cost of providing the care increases. The HPC poses a number of areas for states to consider as hospital at home programs continue to evolve, particularly surrounding mitigating the risk of inappropriate admissions. This is a key consideration for program requirements to ensure that hospital at home is not used as a substitute for lower cost, lower intensity services such as home health care. Hospital capacity is also an area of interest, as hospital at home programs essentially add total beds through freeing up traditional inpatient beds. Standardizing data collection is an important area as well. It's several challenges within Massachusetts on how hospitals decided to code for hospital at home in their discharge data. So statewide or national standards for hospital reporting of hospital at home use, including methods for recording transfers between traditional hospital settings, would improve accuracy in data collection and support efforts for research and monitoring. Other important issues include continuing research on the benefit to patients, including care quality and patient and caregiver experience, determining appropriate payment rates, and financial sustainability, including the need for long-term congressional reauthorization of Medicare's program. To learn more about hospital at home, please see our policy brief, Hospital at Home, Trends in an Emerging Clinical Model, available on the HPC's website.
Wow. That was a very thorough presentation, very dense with lots of information. I'm very impressed. But I think just for the audience, I would like to just like level set one thing, which you did touch on, but is important to this program, is the whole idea of federal funding. And if you could speak a little bit to what is the status of it, because this is about data collection for this program, and it needs to be funded, and we need these patients to use it. So like, just to share with the audience, is this still happening in Massachusetts, and like what does it look like today?
Yeah, thank you for this question. It's an important one. So hospital at home operations are currently paused. Medicare's hospital at home program, which allowed Medicare to pay for hospital at home at parity with traditional inpatient stays, was only authorized through September of 2025. So although there is that language that would extend the waiver, the current government shutdown has caused all programs to pause operations. And sort of financial feasibility and sustainability of these programs kind of depends on Medicare's ability to reimburse for these stays, because they make up the bulk of the discharges. So hospitals are waiting to see how this is resolved, and sort of the future of the program depends on the ability for Medicare to reimburse.
Okay, thank you. Because I did hear you're finding that the age range of the majority of the patients are 70 years old or older, right? So
Yeah.
Okay, that's helpful. There is a question from the audience, and it's saying, a small, quick question for the hospital at home average length of stay. Can you speak about what the distribution of the length of stay look like? Do you tend to see a wider distribution of stay lengths for at home? And I think you did touch on this, and you actually gave some possible reasons for why I think it's a longer length of stay, but this Kenneth, I think, would like a little more information on that.
Yeah, absolutely. So we did note longer lengths of stay sort of within each of our samples in each of the years compared to the traditional inpatient comparison group. And we did explore this by sort of the top 10 most common APR-DRGs within the hospital at home sample. And I believe for all of those APR-DRGs, they also experienced longer lengths of stay for each of those years.
Okay, it's nice when the data aligns, isn't it?
We'll take them where we can get it.
It's validating. So another question that I had, and then we should go on to the next state, but Charlotte, I just know from my experience at CHIA that whenever you have like a new program or a new data initiative or using the data differently, one of the key things is the outreach to the stakeholders and trying to like establish those relationships if they're not already established and strengthen them, especially when you're, dealing with new, different, changed data. So maybe you could speak a little bit about who the stakeholder outreach, who you reached out to. You mentioned state agencies, and just share a little bit about that experience and whether that had an impact on, the project.
Yeah, of course. So the HPC is part of a hospital at home working group, which involves members from CHIA, EHS, the Massachusetts Health and Hospital Association, and this is sort of began as a data collection effort to understand, what's going on with how many discharges do we have for hospital at home in Massachusetts? How are these programs being used? And the partnership with CHIA was just so important to this work because we worked very closely with their data team to, compare methods, to compare our discharge counts to theirs, and then, be able to speak to hospitals running their programs to say, are the results that we share, are they, do they sort of measure up to what you are experiencing kind of on the ground? And so, despite whatever data limitations we may had, we felt very validated when some of the hospitals reported that our findings were consistent with their experience.
Yeah, I love that. Of course, as a member of CHIA, we always love to hear how well we can collaborate, especially with other state agencies, and have successful reports and research like this. So that's wonderful. And we are very proud of our stakeholder and our relationships with submitters. So it's great to hear. There is one more thing here from Laurie Paxson. Is there data that supports better outcomes for patients in hospital and home by not exposing patients to all the factors that happen in the traditional hospital, like staph infections, COVID, et cetera?
Yeah, that's a great question. It's not something that we were able to measure. And, sort of readmissions comes to mind as the thing that everybody's curious about. But there is, literature from, early days of these programs and programs kind of that predated the Medicare program. And there is evidence that, there's sort of less need for sniff afterwards. There's sort of less likelihood of hospital-acquired infections. Patients who might need physical therapy are able to move around in their home in a way that they might not have been able to in a hospital bed. So these are things that people are looking at and trying to measure.
Okay. Yeah. I mean, I think that there's a lot more research to be done, which you mentioned, and that question is a great one, and gives us ideas about what could be looked at in the future. So I think I'm going to introduce the next state, which is Virginia. It is a pleasure to introduce Sophia Shaw and Dawniece Lewis, who are going to talk about using the APCD data to understand health spending in Virginia. So,
good afternoon. I'm Dawniece Lewis, Senior Director of Program Operations at Virginia Health Information, also known as VHI. At VHI, leveraging data to understand healthcare spending, market trends, and care delivery is central to our work as Virginia's steward of statewide health data. At VHI, we oversee core programs that form the foundation of the Commonwealth's data infrastructure, including the All-Payer Claims Database, the Hospital Discharge Database, and Virginia's Health Information Exchange. These programs make it possible for policymakers, researchers, and health system leaders to examine trends and inform decisions across the state. Today's presentation features one of the ways those data are being used across the Commonwealth. Each year, the Virginia Hospital and Healthcare Association, also known as VHHA, publishes the report titled Tracking Virginia's Healthcare Spending and Employment Trends. This report provides a comprehensive look at health spending, payer dynamics, and workforce changes in Virginia. The 2023 report was developed by Onpoint Health, VHHA's analytic vendor, using multiple data sources, including the Virginia All-Payer Claims Database, to capture a complete picture of healthcare spending in the Commonwealth. To share the latest findings, I'm pleased to introduce Sophia Shaw, Health Data Analyst at Onpoint Health. For the remainder of this presentation, Sophia is going to walk us through how health spending in Virginia changed in 2023, how it compares nationally, and what the data suggests about the state's evolving healthcare landscape. And now I'll hand it over to Sophia to walk us through the rest of this agenda.
Thanks, Dawniece. First, I'll start by giving a quick overview of this project and why projects like this are valuable at the state level. So, the National Health Expenditure Account, or NHEA, is a method for estimating healthcare spending by type of service, like inpatient, outpatient, and pharmacy, by payer. This data is released annually by CMS and produced at the state level every 4 to 5 years, the most recent data being released back in 2020. So, this project aims to provide a more frequent capture of state-specific healthcare spending in Virginia. I'll get a bit more into how this is done on the next slide. To estimate future periods of data while also benchmarking to the NHEA state-level data through 2020, we use other data sources to calculate year-over-year growth rates for future periods in categories that are comparable to the official NHEA approach. This ensures that estimates for future periods are consistent with the NHEA data and that there are no discontinuities between the official NHEA data and more recent projected periods. The projections in this report leverage data from the Virginia APCD, as Dawniece mentioned, the Bureau of Economic Analysis, and CMS 64 data. It's important to note that most of these projections are based on a combination of data sources to account for limitations that may exist among each independent source. The multi-source approach allows a more complete view of the Virginia population and total spending. For example, to derive population estimates, KFF and ACS data were partnered. Similarly, APCD and CMS 64 data were paired to understand Medicaid spending. MAPS data collected by ARC was also reviewed to better understand premium and deductible trends in Virginia's private insurance space. We don't have time to unpack the entire report, but I'll focus on a few of the biggest takeaways. First, we have a high-level view of Virginia's annual personal health care spending growth. As I previously noted, you can see the distinction between the dark blue bars, which were directly derived from the NHEA state-level estimates, and the turquoise estimations derived from the methodology we followed. Since the NHEA state-level reporting is only available through 2020, the APCD and BEA, along with the other sources mentioned, are used to estimate 2021 through this year's report for 2023. This report is designed to be able to use the NHEA data when released as a benchmark against the APCD and BEA estimates. Virginia healthcare spending in 2023 reached an estimated of $91.9 billion, which is roughly 10% higher than 2022's estimated spending. This is also the highest growth rate the state has seen yet. Next, we've categorized the $91.9 billion into spending by category. You can see that hospital spending alone made an estimated $33.4 billion, roughly 36% of the state's total spending, with physician and clinical services the next highest category at $23.9 billion, or 26%. Home and residential spending is next, followed by prescription drugs. For clarity, the smaller categories, including dental spending, durable medical products, and other professional spending, were combined, contributing to less than $10 billion in 2023. Although not shown here, the ranking of these categories echoes last year's report, with hospital spending also as the largest contributor. I'll also add that these spending categories align with those reported in the NHEA and SHEA reports. We've just combined categories for clarity on this specific visual. For example, we've truncated all home health and nursing home affiliated costs in this figure, but do have more granular cost estimates for home health, nursing care, and residential care separately. Next, we show a bit of context behind the spending categories previously showed by categorizing PHC spending and enrollment growth by payer. You can see that Medicaid has the highest average year-over-year spending and enrollment growth from 2019, followed by Medicare. Private health insurance, on the other hand, in Virginia experienced pretty slow enrollment and spending growth. I'll remind you all that this work was completed last year, reporting on 2023, so we were not quite yet seeing the impact of pandemic-related benefits unwinding in the data. As these benefits are reviewed and potentially reallocated, we may see private insurance grow in Virginia in future years' reports. In this next figure, we show how Virginia per capita spending by payer compares to national estimates. Although Virginia has less per capita spending than the national estimates across all payer types, the overall trending across payers follows the national trend, with Medicare leading spending. This report also investigates state premium and deductible data reported by ARC. This piece of the analysis is unique to this project, and it aims to better understand and compare trends between overall private insurance spending and rising premium and deductible costs. The ARC data reports at both the individual and family level. Both premium and deductible rates have been steadily rising since our pre-pandemic period in 2019, about 20%. Not shown in this overview, but included in the report, is Virginia's premium and deductible rates compared to national estimates. The average individual premium in Virginia was pretty comparable to the national rates, but the family average premium was about $300 higher than the national benchmark. Next, we'll identify a few takeaways coming out of the trends shared. Overall, healthcare spending continued to grow in Virginia. As mentioned at the top of the call, projected spending in 2023 was roughly 10% higher than 2022. Despite this growth, Virginia remained below the national average, with notable lower spending on hospitalizations, prescription drugs, and home-based services. There are a number of factors that are driving this growth, both nationally and in Virginia, but Virginia specifically has pressure from their aging population and overall higher utilization of services. As we head into investigating 2024 trends, we'll keep our eye out on out-of-pocket costs, specifically around prescription drugs, as well as increasing labor costs. We will also continue to monitor the growth of home and community-based care in Virginia. And finally, we'll close with challenges and opportunities that present with this type of project. First, most of the data supporting this project is public, which introduces challenges around inconsistent timing of refreshes, consistency of data reported, and of course, with all data, the possibility of errors. More recently, data access and availability concerns have presented, creating unknowns around refresh timing for federally supported data sets. Next, keeping it all organized. Since this expenditure project leverages a variety of different sources, oftentimes there are different definitions for total spending and a variety of methodologies to understand in order to accurately combine data. This, paired with the complexity of data being a combination of both published and projected data, make it challenging to create consistent time series. And finally, the variation between the national and state expenditure account methodologies make finding a standard difficult. However, despite these challenges, we were still able to create the trends shared and more to better understand Virginia's healthcare landscape. Before fielding any questions about the report or all the work happening at VHI, I do want to acknowledge my colleague Jen Perloff for her help on this project, as well as Alterum, who originated this methodology when analyzing these trends back in 2022. Thank you.
Hello. Wow, that was quite impressive. And I love to see the use of APCD data, because it looked like that it wasn't until more recently that you started using that data to calculate these metrics. And then I love how you showed some challenges, but were able to overcome the challenges to provide this very rich, helpful, informative report. So congratulations on that.
Thank you.
I did have a question. I was wondering, when you were talking about emerging trends and out-of-pocket costs as something to explore, maybe you could explain a little bit about how you did either measure or not measure out-of-pocket costs in the existing report.
Yeah, that's a great question. So that is kind of a piece of the report that we're actually hoping to expand and kind of make our own in this year's report for 2024 spending. So right now there's kind of just a catch-all bucket in the report. It wasn't really touched upon in this presentation, but kind of a catch-all bucket of just other spending. So this kind of captures out-of-pocket spending, spending from the uninsured population, spending from other payer categories that aren't represented by the main private insurance, Medicaid or Medicare payer types. So that's kind of what we're hoping to do with this next year's report is better kind of carve out what directly is attributable to the out-of-pocket member burden rather than what Medicare or Medicaid or private insurance entities are covering.
Okay, and thank you for being so transparent about whether it's in or it's out. And so I think it's in the other, but the measurement could be improved. So there's always room for improvement. Thank you for sharing that. There are some questions that are coming in. Have you had any public reactions to this data, news outlets, et cetera?
Yeah, maybe not public, but we were able to do a presentation to the staffers last April when I think this was released in February or so. So less so public, but we were able to kind of publicize it a little bit amongst a pretty informed group. And the reception was great. Alterum had done this report previously, so it wasn't a new report or new methodology that people were responding to for the first time. So I think that helped kind of facilitate traction. But obviously, we all know healthcare costs are on the rise, and this is becoming an increasing target both at the state and federal level. So I think there's going to be a continued kind of spotlight on reports like these to really dive in at the state level when there are kind of federal gaps in data.
100% agree. So that 10% increase to me was somewhat alarming. And there is a question here, what are the main factors behind the estimated 10% increase in 2023? For example, prices versus utilizations. Apologies if you covered this. You did talk a little bit about the increase, but yeah, it'd be great to hear a little bit more.
Yeah. So our understanding mostly that really what's driving a lot of that 10% is the aging population that Virginia has. So higher costs in the Medicare population itself, not necessarily an increasing number of members in that population, but higher costs, more tricky costs in that population. There's also kind of growing speculation, or I guess interest in better understanding the utilization rates and really kind of trying to decipher if it's an increase in utilization of the services that are rising the costs, or if the costs are kind of due to inflation and increased charges, rather that be at the hospitals or other entities charging.
Okay. So in terms of utilization, that's something that you still need to kind of dive into.
Yep.
Okay, that's helpful. Kyle is asking, would having wider access to RX rebate, non-claims payment further refine the analysis? Well, I mean, I know that always improves it. I can't remember. So this is not included in your analysis.
Yeah, that's a great point, Kyle. So we didn't really dive into the pharmacy space in this report, particularly breaking down that kind of bucket of pharmacy spend. I would say the rebate information is probably encapsulated in that overhead bucket, but it's helpful to understand what specific drugs are really creating those larger rebates. So I think more data is always better. Dawniece and I are both really in the weeds in our roles with data. So I think more data is always better. And if we could get the rebate information, that would be awesome. But I know that's not the easiest to collect.
Yeah, right. But it's helpful, like for all the states to hear that, because it is a challenge. Some states are further ahead than others, but it's always helpful to kind of collaborate on this. Okay, I think that's all I see for right now. You guys have anything you want to say, or should maybe a random announcement for those that are playing the token game? Don't forget to enter the tokens from today's session. And they're probably giving us the token for this session. I'm not sure. I guess not. Okay, so I'm going to move on to Vermont. And actually, it's a great transition because they're going to be talking about prescription drugs. It is an honor to introduce Hiroko, Meserve, Michelle Lozano, and Kate O'Neill, who are going to be talking about reference-based pricing approach with Medicare maximum fair share. Take it away.
Today, my name is Michelle Lozano, and alongside my colleague Hiroko Meserve, we will present to you our current work in exploring a prescription drug cost regulation program for the state of Vermont, and more specifically, how it would look like if we took a reference-based pricing approach using the Medicare maximum fair price, also known as the Medicare MFP. Our presentation will consist of the following sections: a briefing on our project's mission, an overview of current prescription drug spending in Vermont, using the Medicare MFP as a reference-based pricing approach, our key findings leading to insights and takeaways, and finally, a Q&A segment. Our mission. As authorized by Vermont Act 134, the Green Mountain Care Board, or the GMCB, Prescription Drug Affordability Program, in partnership with Onpoint Health Data, is working to reduce prescription drug costs in Vermont through evidence-based strategies. Using Vermont's all-payer claims database, also known as VCures, the team projects savings and evaluates the impact of extending Medicare's maximum fair price to all payers across the state. Now we're going to shift over to take a look at Vermont's prescription drug spending. To start us off, in analyzing the state's all-payer claims database, it was found that while generics account for 82% of prescriptions filled across all payers, you'll be able to see this on the left diagram in the yellow, it is brand name drugs that drive nearly 86% of retail pharmacy spending, particularly among the Medicaid population, where brand name utilization remains significant at nearly 22%. And the diagram on the right in the dark green, you'll be able to see exactly how much of that spending cost is attributed to brand name drugs. On a broader note, prescription drug spending in Vermont continues to rise, reaching nearly $1.2 billion in 2023, despite long-standing efforts to control costs. It's important to mention that we use data up to 2023 because this was the data that was most complete at the time of our project. However, as we're entering now into 2026, it is most likely of all cases that we have surpassed this threshold of $1.2 billion in spending. Importantly, Medicare members face the highest burden in the state, nearing $600 million in spending. However, nonetheless, it is all payers across the state that are experiencing this increase in prescription drug spending. Now I will hand it over to Hiroko.
Reference-based pricing approach with Medicare maximum fair price. The Medicare Maximum Fair Price Program, often called MFP, was established as a part of the Inflation Reduction Act passed in 2022. Its purpose is to negotiate drug prices directly with drug manufacturers for medications covered under Medicare Part D. Starting January 2026, the first 10 drugs under this program will have negotiated prices, and the program will continue to expand over time. These drugs are high-cost and single-source medications that currently have no generic or biosimilar alternatives. According to CMS, these negotiations could save Medicare Part D about $1.5 billion in 2026 alone nationally, by reducing the prices by as much as 80%. This means that beneficiaries will have a lower out-of-pocket cost. Here is a list of 10 drugs selected for the MFP program in 2026. Among them are 3 specialty drugs. You can find the full list on the CMS website. It's available for download. The file includes the negotiated price for a 30-day equivalent supply, along with a national drug code crosswalk. Using 2023 pharmacy claims data, we projected the savings with the MFP prices. Let's go over the key findings from our analysis. Here, first, when we talk about total spending, we are referring to the allowed amount, which is the combined amount from paid by payers plus the out-of-pocket costs reported in the APCD. The spending on the retail pharmacy drugs increased steadily year after year, and so did these FMP drugs. From 2018 to 2023, overall pharmacy spending grew by 46%, and remarkably, the total spending on these drugs actually doubled during the same period. Moreover, these 10 drugs accounted for only about 1% of all pharmacy claims in Medicaid and commercial. But despite the small share, they made up more than 12% of total pharmacy spending across Medicaid and commercial plans. This chart shows the percentage discount for each MFP drug based on a 30-day equivalent supply. When we compared the negotiated prices to Vermont's average prices, the discounts ranged from 40% to as high as 80%. To wrap up, here is a key takeaway. Medicaid and commercial plans could save about $40 million from just these 10 drugs. That translates to roughly a 6% reduction in total pharmacy spending. This is a pretty significant impact for such a small group of medications. The dramatic savings were observed in 2 specialty drugs and a few popular drugs for diabetes and cardiovascular disease. Lastly, let's talk about considerations and limitations. This analysis is a great example of how APCD can be used as a primary source. But there are a few important caveats. First, many Vermont commercial members are enrolled in self-insured plans. Not all the self-insured plans submit their data to the APCD. So, to address this gap, we projected the savings for these missing members using an imputation method applied to a prior work with GMCB. Second, 2023 data was the latest available at the time of analysis. So, applying an inflation factor based on the Consumer Price Index from the Bureau of Labor Statistics could help to project savings for more recent years. Finally, pharmacy manufacturer rebates are not publicly reported in Vermont, and therefore, the rebates were not factored into our estimates. So, including rebate data would give a more accurate picture of the impact by the MFP model. Now I will pass it back to Michelle. Thank you.
Thank you, Hiroko. To conclude, we will look at insights and takeaways from our project. It is important to mention that our project does not conclude with the results found. We want to ask what they mean and the consequences that they can have on the affordability and accessibility of quality healthcare for the population. To start, using the Medicare MFP as a ceiling price benchmark could result in increased affordability across payer types. Secondly, this approach upholds regulatory alignment as it mirrors federal negotiation mechanisms and remains in compliance with existing legislation, while enhancing the market leverage. This is important as Vermont is a small state. And finally, there is a possibility that equity could be enhanced as aligning non-Medicare populations with MFP prices can narrow affordability gaps between public and private insurance coverage payers. Needless to say, this is just one of many strategies that are being explored to control the rising costs of prescription medications. Now we're happy to answer any questions you may have. Thank you.
Wow, that was wonderful. Congratulations on that report. It was a great use of APCD, even though you had to overcome a bunch of challenges. And just to name a few, where you needed to impute the self-insured, you needed to apply inflation factor to deal with the old data. So very impressive work, and gives the opportunity for huge savings. So congratulations. I did have a question for you guys. One question just in kind of researching your work, and that I noticed that this Act 134, one of the major provisions of Act 134 in Vermont was analyzing hospital financial health. So maybe you could just speak to a little bit of why and that you pivoted to prescription drug affordability, which is a very important area, but I'm just wondering how you decided on that pivot.
I'll jump in. It's not so much a pivot as it is an add in addition to. We are also working very carefully and diligently on hospital sustainability efforts here in Vermont. So the prescription drug affordability work is also an investment that the state is making to understand better. And this analysis is an example of ways in which we can understand better how prescription drug cost trends are really rising, and we're looking at ways in which we can tackle prescription drug affordability with a variety of options.
Yeah, and I think you guys had some great findings. Thank you for that. As you mentioned too, that this does not conclude this study. So maybe you could speak, and I will probably ask this of the other two presentations too, but I'll ask you guys first. Maybe you could speak a little bit about what the next steps are, given all this information that you did learn. And I think you touched on it a little when you were exploring future implications, but we have a little time that maybe we could hear about next steps.
Yeah, of course. I can jump into this one. Hi, everyone. So Medicare as a reference-based pricing approach is just one strategy that we're using to look specifically at brand and specialty drug to control the cost rising of those. However, we're also looking to increase efforts in our team for transparency and how we gather that data, and if possible, how we can aggregate that data into one big platform. We're also looking at another strategy that will tackle generic drug prices as well, and how we can use another sort of reference-based pricing for that. That's a whole other project. But just to say, this is just one specific strategy that's looking specifically at brand name drugs. And there's a whole other list that we could go through, whether that's generics, whether that's transparency, cross-payer analyses, and thankfully, the Onpoint Health Data team has been a great partner to achieve that so far.
And I can add in too that we are leading up to a final report to our legislature that will summarize our learnings, analyses, and offer recommendations. And we intend to work collaboratively as a state to identify some of the best recommendations that we might be able to implement. So that would be an early next step. And as Michelle said, hopefully we're going to be implementing some of the the opportunities that we have for strategies to reduce the cost of prescription drugs. And if nothing else, we are looking to expand price transparency. One of the ways in which we are currently doing that, which is new in Vermont, but this year we will be collecting Hospital 340B data, and we are working on that reporting guidance right now to issue to hospitals, and we will be reporting on that in the coming year.
That's helpful to understand. So another data collection, and that's a big undertaking. And so it begs the question for me, what about the pharmacy rebates? Is that something that's on the horizon to do some collection around that?
Yeah, we have made an effort to collect pharmacy rebate data. We need to revise our data reporting manual in order to do so, and the staff has made a recommendation to the Data Governance Council here in Vermont, which did approve it, but there's some complications that the team is working through with collecting those data from payers, and so that change is not in place yet. I will say, though, that we are very, very interested in collecting pharmacy rebate data, and we'll continue to try to find the right mechanism for doing that, and the opportunity to do so in the future.
Yeah, you're pursuing it, and I think that there's members here at NAHDO that can help you and partner with you to get through that. So I'm confident that eventually you will have that, and so I think, Norm, maybe we want to bring everyone back and see if I know there's at least one outstanding question that I want to make sure we cover. Actually, there's a bunch of questions, but one that I wanted to start with for the Hospital at Home program, if Charlotte's here, Chris Frenier would like to know, have you had the opportunity to do any within facility analysis comparing hospital at home versus inpatient at the same facility? For example, is the gap in charges between the two types of care within the same facility also narrowing over time? And I think you did talk a little bit about this, but this is a great question. So Charlotte, I'll let you speak to that.
Yeah, thank you, Chris, for your question. We did perform some kind of investigative by facility analyses, but the kind of within year facility level discharge counts were relatively small, so we didn't focus too much on them. But we did hear from stakeholders that some of the programs that are part of like larger hospital systems had patients or cases that were very similar between the two settings. And I would imagine that would translate to, like, to some degree, to hospital charges. And additionally, programs that were part of these larger systems likely had more similar charges more similar charges than smaller programs because they have the infrastructure, the logistics in place, kind of built for one hospital that all of the hospitals approved for a program within the system can use. So I think there's a little bit of economies of scale at play there.
Thank you, Charlotte. We have another question for Vermont from Jen Perloff. In terms of prescription drug price transparency, has Vermont considered profiling prices at the pharmacy level? I'm sure that that's not a simple thing. It's an easy question, but within the data, that's not always easy. But I'll let you guys answer.
It's a short and sweet answer. We have not.
Okay. And another question, I think for Vermont, Jonathan Hinsborough, any pushback from your stakeholders on seeking rebate data? Well, you guys really haven't gone after that yet, so you may get pushback. We don't know, but you might not have experience yet.
Exactly. We haven't exactly gone after that yet, as you said, Betty, but I know we want to mirror practices done, for example, in Oregon and Texas, that they've been able to collect this rebate data, as long as it doesn't trespass in the field of Medicaid, since there's a federal law prohibiting that. So we are trying to expand our efforts, but we'll see the responses we get. And hopefully before we do that, we would touch base with our stakeholders, because that's something we really like to do at the Green Mountain Care Board, just to make sure that everyone's updated on these processes before we implement them.
I love that answer.
Betty, can I jump in on a question that was not directed at VHI?
Please.
Just in case anyone's curious, Virginia's actually, we just closed our comment period on reaching out to all the health plans and data suppliers to see what the feedback would be if we proposed adding the new non-claims payments data layout that NAHDO unfurled this year. And just let you all know, if anyone's interested, it's been really interesting because it was a relatively silent comment period. Like, we did not get a lot of pushback from the data suppliers at all when it came to that. From Medicaid, yes, but all the commercial plans, we either did not receive a response or we received a response that was more about like what's the implementation time. So I thought that was really interesting. That's something Virginia plans to go forward with in our next General Assembly for 2026. So more to come.
Yeah, that sounds like good news, and I like to think that the lack of pushback means that they have the data and they just want to figure out how they can get you the data, right? Let's be positive about it. So thank you for sharing that. I don't know that we have. I think I covered all the questions, and so we just have like 2 minutes left, and just back to this idea that none of these studies have concluded, and Virginia already spoke, but Vermont and Massachusetts, anything you want to say about next steps, next phases before we wrap up?
Sure, I can say a few things. I, again, just want to highlight sort of CHIA and the working group's efforts to improve kind of the collection of this discharge data. So something that we heard was, one of the organizations used that site ID to capture their hospital at home discharges. And this was actually the most accurate, between what hospitals reported and what we were ever able to measure in the data. And so there are, some ideas, and I think, moving forward, we're going to look to use that site ID to kind of implement and continue tracking discharges moving forward if the program is reauthorized.
Oh, wow, Charlotte. There's always room for improvement, and I'm so glad that you're here to tell us about that site ID. And it's absolutely something we want to make sure is useful to you. So thank you for sharing that. Anything from Vermont?
I don't have anything additional to add. Yeah.
Okay. All right. Well, thank you. We are almost at time, so I'm going to give this back to Charles and Norm. But thank you all for hanging out all day and with us and doing this. It was wonderful. Thank you.
Oh, no, thank you, Betty. Thank you for organizing this, and for all of you for your fabulous presentations, for your answers to the questions, and to the audience for the questions. It really does make the session so much more interesting when we can respond to what's on your minds. Coming up next, of course, everybody gets a nice rest tonight. Tomorrow morning at 11:30 a.m. Eastern, we will have another virtual coffee shop, chance for you to come and meet people and network, find friends, find connections. We did want to mention, we put this in the chat as well, but if you're interested in the CDL, the common data layout, and especially about non-claims payment, those will be covered in much more detail tomorrow in our closing plenary session. So you want to make sure that you put that on your calendar tomorrow at 4 p.m. to attend that closing plenary session. So with that, I'm going to thank everybody, and we're going to break until tomorrow morning. We'll see you all then.